welcome, like I mentioned, to thank you for that. Please use the chat function to introduce yourselves, a land acknowledgement based on where you are joining us from today, and anything else you would like folks to know. Again, if you have any questions or comments for the presenters, please put them in the Q&A box. If your question is directed to a certain speaker in particular, please identify this in your question, and we'll be saving all the questions to the end. We'll also be providing after the webinar this afternoon an anonymous survey sent out by email. We would really appreciate your feedback so we can continue and improve to grow. And if you'd like to learn more about SUNAR, please visit us, like I said, on our website, www.sunar.ca. Check us out on Facebook as well. It's Sun Atlantic Region, and I believe Carolyn will put that in the chat. So moving right along, we'll bring up the land acknowledgement. Good. So this is our virtual SUNAR webinar land acknowledgement. SUNAR would like to acknowledge that we're all sitting on the unceded and traditional territories of Indigenous people. Together, Nova Scotia, PI, New Brunswick, and Newfoundland are traditionally called Mi'kma'ki. Our members in Nova Scotia and PI are situated on the territory of the Mi'kmaq. In New Brunswick, we are sitting on the land of the Wolastoqiyik, otherwise known as the Maliseet or Mi'kmaq. We respectfully acknowledge Newfoundland, the Undahumguk, in Mi'kmaq as the ancestral homeland of the Mi'kmaq and the Beothuk. We recognize the Inuit of Nutassinuavut and the Inuit of Nutukavut and the Innu of Nitassinan and the ancestors as the ancestors and original people of Labrador. Please join me in a moment of reflection to acknowledge the harms and mistakes of the past and to consider how we may care for each other in our own way to try to move forward in the spirit of reconciliation and collaboration. Thank you for that. SUNAR also strives to be a safer space, so we have a safer spaces statement. We use this in all of our regional meetings and any webinars we do. So in this virtual space, we will treat each other with respect and dignity, regardless of age, race, gender expression, gender identity, sexual orientation, levels of ability, spiritual practices, and all other diverse identities. Everyone entering the space has a responsibility to uphold these values. SUNAR is committed to and encourages all those who gather with us to speak from personal experience and avoid speaking on behalf of others. Try to use I statements to share reactions or experiences such as I feel or I am affected by. Do not make assumptions about others' identity or experiences. Listen to each other so we understand the various perspectives. Share beliefs, opinions, and points of views rather than judgments. Maintain confidentiality. Information shared here should stay here. Be mindful of pronouns of others and use them. It is okay to ask if you don't know. We're all here to grow, to connect, and share our experience, knowledge, and light in this space. Thank you for that. All right. So moving right along still, we have some information about how SUNAR came into existence. So before we introduce the presenter, I'd just like to go through that, I'd like to go through that with you. So I want to tell you briefly about SUNAR and the organization that is hosting this webinar. Direction 180 received funds from Health Canada's Substance Use and Addictions Program, otherwise known as SUAP, to create SUNAR, the Substance User Network of Atlantic Regions, back in August of 2020. SUNAR project seeks to adapt a peer-led model based on the needs of people with lived and living experience of substance use in 8 communities across the 4 Atlantic provinces: Truro, Sydney, Halifax, Nova Scotia, St. John, Fredericton, Moncton, Charlottetown, PI, St. John's, Newfoundland, and actually as I read this, I realize we've added a chapter at Amherst as well that we're getting up off the ground now. SUNAR aims to unite, inform, and open a dialogue between people who use substances in Atlantic Canada. It also strives to increase engagement between people who use substances and service providers and policymakers to decrease substance use-related stigma and isolation, and increase evidence-informed policies, programs, and practices. Ultimately, SUNAR works to enhance and save the lives of people who use or use substances. And with the help of key partners and harm reduction organizations, one of them you see on the screen is here today, Riverstone, and some are in attendance. So thank you for that. We really appreciate the support and allyship. Throughout Atlantic Canada, SUNAR engages with a network of approximately 40 people with living and lived experiences using substances to participate in knowledge exchange, skills-based workshops, and other capacity-enhancing activities. We also have a newsletter that goes out. Lots of people take part in it. It's a place where people can have a voice. It's also a place where you can find out about education, harm reduction, events happening in your community. So anyone who signs up for the monthly newsletter, which is a collection of harm reduction and substance use related resources in Canada, gets that. I write interpersonal stories trying to empower and highlight the amazing knowledge keepers and lived experience folks of people who use substances. And it has a focus specifically on the Atlantic provinces. And Carolyn will put a link in the chat for that. And if you want to become an ally of SUNAR, that's a great place to look, as well as our social media. So without further ado, I'm going to introduce the speakers today. We have Michelle Pittman from Riverstone. I cannot see the next slide though for some reason. Do you mind bringing that up there, Carolyn? And I have Dr. Davidson. I actually, like, full disclosure, I work with these folks too. So I'm lucky to have my feet in both places, and I'm lucky to be supported by them both. If I continue talking about how much I enjoy these organizations, I guarantee you see me trauma cry smile on this lovely venture. I realize I don't have the bios pulled up there. Could you pull those up there for me? If not, I can introduce them verbally.
That might be good, Steve, if you don't mind.
Sure. Sorry, Dr. Davidson, a little ad lib. I had your bio, but Dr. Davidson, I know as an amazing doctor, full of compassion, breaks down barriers, opens doors, has helped my family extremely much, and I've seen them help tons of people in the community. Also, Michelle Pittman is a nurse at Riverstone, cut from the same cloth, very open with their discussions with folks, meets people where they're at. And I've never seen folks in a medicalized model work so closely for community and so openly with individuals. And I'm really honored to give them a space to speak about their program, to give a lot of people a space to exist and find a place to be okay. I hope that was a good enough an introduction. And without further ado, if you would take it away, Dr. Davidson and Michelle Pittman.
That was better than our bio, Steve. Yeah, we're just getting our screen share up here and getting our full slideshow. Can you see that, Steve? Just a thumbs up. Yeah,
everything's cool.
Awesome. And Steve, I don't know if you're able to tell me, I can talk a lot, and Michelle somewhat. How long should we talk for versus Q&A part, if you don't mind giving me a cue?
Yeah, I will let you know. We're done at 2, so maybe just reserve half an hour to 20 minutes for the Q&A, if that's okay.
Oh, that's perfect. Thank you.
Yeah, thank you.
So just to clarify one thing, I'll let Michelle introduce herself, but she's actually a newly minted nurse practitioner, which is super exciting and a hell of a lot of work. So we have to acknowledge that too. So yeah, I'm Dr. Sarah Davidson, go as Sarah here pretty much. And originally from Upper Canada, but moved to the East Coast 20 plus years ago to just have our family out here because of community, and have not looked back. Didn't know I was going to be a doctor at the time, but after working with AIDS New Brunswick, I actually was very inspired to try to do whatever I could to help harm reduction, and thought it was crazy what was happening back in the early 2000s around lack of access. And so fast forward through a long, interesting story I won't share here, ended up going to medical school and hit the ground running. And so I'm very grateful to have all the opportunities that I have, and very grateful for SUNAR to give us the opportunity today.
So I'm Michelle Pittman. Yes, I'm a new nurse practitioner, and I'm also the clinic manager at Riverstone. Sarah and I have been with Riverstone since the very beginning. I originally became a nurse back in 2016, and I've always been working with the population that are entrenched in homelessness or have substance use disorder. And I just knew that it was a population that I wanted to work with for my entire nursing career. So Riverstone has definitely opened up a lot of doors, great opportunities, amazing networking, meeting all of these great people. And I'm really happy now that I'm a nurse practitioner to be able to offer primary care to the exact same population that I want to care for my career. So yeah, I'm very excited to be here today and for us to share what the amazing things that we're doing here at Riverstone.
So I know that Stevie did an excellent land acknowledgement, but just to hone in a tiny bit more for us. So in Fredericton or in New Brunswick, the unceded territory of the Wolastoqiyik, and that is a combination with the Maliseet, Mi'kmaq, and Passamaquoddy and the whole region. The Peace and Friendship Treaty was signed in 1725, and there was no handing over of land. It was the idea to try and build on friendship and build relationships. So it's important to acknowledge we're doing that today here, but there's so much more that settlers can do working with Indigenous populations and people and leaders that are already here to learn from them about how we can build right relationships. So we'd like to keep working on that. So I'm going to start talking for part. We'll have Michelle talk for parts as well, and we'll kind of share that way. But excited at the end to talk about this, and I'm hoping this will be very relevant, but feel free to ask whatever questions you have. I just put this slide up just to show that substance use isn't always a disorder. And then we'll say substance use disorder. We're trying to change because we are a medical clinic. So some of our language is more medicalized, but it's to acknowledge the fact that a lot of the change that needs to happen nationally and even provincially is through a healthcare lens, even though there should be alternate ways outside of healthcare to have people who use drugs remain safe and be supported. But so forgive if you don't like substance use disorder, my apologies. It's not meant to offend. It's meant to get away from terms like addict and to just frame it as a health condition that has a health response. And again, me being a doctor, I'm kind of in that realm, but I'm trying to carve out space for alternate ways. But anyway, so this slide will show that there is a continuum that all of us use substances, obviously, to modulate our experiences on the planet. At some ends, some people may abstain from substances. The other end, it's become to a point where it's really interrupted their ability to function and led to harmful outcomes for them and at risk because of toxic overdose crises, toxic drug supply. So this is just to show us again, because we show this to more than just people who already know. We show this to a lot of people that don't know. So we want to call into question. It's not an abstinence or not. It's not a binary either or. And in fact, lots of people are using substances and might have some right now in front of them and might be using them again tonight. So just to frame that for everybody. Again, it's a bit of a medical terminology slide, but the important part on here is just to look at when it's become a disorder, chronic relapsing illness, but that it does have incredible high risks of morbidity and mortality, which means people getting really sick or dying. And that's not necessarily from the actual substance use itself per se, like the actual using of modulating substances. It's more the environments that takes place within, the toxic unregulated drug supply, the harmful outcomes when people are so stigmatized within healthcare that they can't reach out, and the fact that a lot of the poverty and food insecurity and things that sometimes go with that has been downloaded to healthcare rarely to fix. So we are trying to push that other areas of our government will also pick up the slack. But for now, a lot of it lands in healthcare's lap. And the other important piece is that there can be sustained remission, and whatever that means for people, that they actually may move from where it's become disordered into ordered, and that can take many different journeys. This is a giant slide. I offer this just because it'll be available online after. You don't have to memorize it, no quiz at the end. I don't think I'd be able to memorize it. But it's to show that there definitely is a neurochemical change that can happen in people's brains, in their systems. And that's the circle, showing that the more that there is using that's becoming problematic for that person, the more it actually creates some physiological changes, which then those become a feedback loop that just feeds upon itself. And again, this slide is offered to show that just the idea that people can just stop using drugs if they become problematic is really challenging, and it's not realistic, and it's not evidence-based, and it's not harm reduction oriented. And so we need to look at how we can educate people in the broader community that no matter what condition anyone is working through from a healthcare lens, it's usually not a black or white either or. So again, here's just 2 slides about that. Forgive the detail, but they're available, and we can share these slides after if anyone's interested in the pathophysiology. More importantly, this was from a medical journal. So that's where people will look for the evidence base when they're trying to make policy decisions, if they're policy informed by evidence, which some governments are not. But anyway, this is just basically showing relatively recent assessment of people that tend to die from substances. There's definitely a correlation. So there's an association made with poverty. In a nutshell, that's really what this is showing, is that people that already have other factors that marginalize them and that exist within spaces that are not taking care of their financial needs, and the whole host of other reasons, disability, being racialized, indigenous, queer, neuroatypical, all the other reasons that people might already be existing within the spheres of poverty, it is definitely the biggest driver that can lead to death from toxic drug supplies. And this is also just kind of parsing it out a little bit more specifically. You'll see the third point down, the ACE score. Some of you may or may not have heard the Adverse Childhood Event Score. There was over, it wasn't quite a decade. I'm sorry, I'm not remembering the exact years, but it was in the early 2000s down in the States. Kaiser Permanente is one of the insurance companies. They did this huge study of about 40,000 people. So really, really, really big numbers. And they were asking, it was a survey to see people what experiences they had in their childhood and what their health outcomes were. So it was the first really giant study to show that people that are exposed to adverse childhood events, that's what ACE stands for, are at much higher risk of early death, substance use disorder, even pregnancy, cancer, heart disease, like the psychosocial issues, the issues around someone outside of their pure genetics. And the fact they smoke, don't smoke, those things are sidebar. All of just their poverty, their racial, all those different things can actually lead to specific health outcomes. We know that intuitively, but there is actually this study called the ACE score. So if you're ever interested in looking that up, it's a very powerful one. The flip side is the resiliency score, because lots of people might have a high ACE score, but they also maybe have incredible high resiliency score. And those are the people that we all know and love that are still alive despite what they face. Again, another big slide, but it's important just to show, this is from the center, the Canadian Center for Substance Abuse, national organization trying to gather the data to contribute to the best evidence base. And I keep doing air quotes because our different government leaders might use evidence differently. So I actually mean evidence. So I'll stop air quoting, but the evidence base, meaning the data, the information that we gather in as objective a way as possible so that people will be able to lean on that information to make decisions. So the CCSA is a great organization, and they're trying to further that so that all across the country we can learn and figure out what to do. So this is showing the cost in New Brunswick. So I'm sorry, I don't have, we can look up other spots, but we're a bit New Brunswick focused. So in general, substance use costs $1 billion a year in New Brunswick. And that is for all of the substances. So you'll see there's a bit of a red circle around one highlighted area. That is for stimulants and opiates and other kind of recreational or non-pharmaceutical drugs. To the left of that is a big red and a brown. That's actually alcohol and tobacco. So it's really to contrast how much tobacco and alcohol cost the province versus the other substances. But yet there can be, there's definitely fairs and shows and all sorts of celebrations and festivals about alcohol and maybe somewhat less tobacco, but those are well esteemed, and yet they cost the province much, much more. But again, it's still $212 million with those three little ones added up that it's costing the province per year. And I imagine if they took even a tiny portion of that and invested it in harm reduction, into housing specific for people who actually need it, and services in peer support networks and a whole bunch of stuff, we'd be able to reduce the morbidity and mortality of those numbers. But it's sometimes hard to convince people. So the need for programming, again, a lot of words here, but essentially 1/4 of people in New Brunswick will struggle with some type of substance use disorder. That doesn't mean more than that use substances, but those that might fall into a disordered state. And New Brunswick has the second highest rate of intravenous drug use in Canada. So BC is first and New Brunswick second. We have a lot less people than BC, but in terms of per capita, how many people inject drugs, it's hard because it's not as studied an area, but approximately 1% of the population of New Brunswick injects drugs. And that was back in 2019, I believe, those numbers. So it's possibly that it's gone up for sure because the availability of more substances has just filled the Atlantic Canada, as you all know. Then it's obviously toxic, unpredictable. So over a 6-year period in New Brunswick, there's been 486 overdose deaths that have been recorded by the coroner. It's possible those numbers are higher, but that's probably relatively, and I know that's a big number to just throw out while I'm talking loudly, because that's, it's tragic to think of anybody dying. So I just want to take a moment and acknowledge that this is just a terrible loss. And roughly half of those, slightly more than that, were specific from opiates. And then just last year, out of the 86 people that died last year, 17 had fentanyl or nitazenes, bromazolam, or itozolam. I must admit, that's a new one to me, the last one. Atizolam. Those last two are benzodiazepines, so they don't respond to naloxone, and they're just entering the toxic unregulated supply. We used to have a slide about how many people were non-fatal overdoses, but as we all know that so many people don't call the coroner, call the ambulance, call anybody when there's overdoses. So we don't even bother that number. It's astronomical. And then on the far right there, so there's been over 1,000 people that have asked about our services here at Riverstone since we opened, which is just a couple years ago, and over 600 have become active participants. Some have left us for various reasons, but in general, that's how many have been interested. Just a clarifying slide, a lot of people call our clinic a safe injection site, and I don't mind in the least because we desperately need safe injection sites in Fredericton. We're not, though. The big difference is we're an injectable opiate agonist therapy. More slides to come on that. So iOAT program. What that means is that I prescribe all the medications, and Michelle will also be able to pretty soon when she finishes writing her exam in a month. But we prescribe all of the medications that are injected in the clinic. And the nice part of that is people will know what they're injecting. And it helps to decriminalize people's drug use so that they can come in, they can inject a prescribed medication in a clean clinical space. We have a slide coming with a picture in a sec. And then they can not have to necessarily worry whether their shot's going to kill them or not. Now, a lot of people are still using outside for a variety of reasons. Some have stopped altogether using outside, but some still do. So the risk is still there. But we are trying to help decriminalize people and help keep people alive. Again, we need a safe injection site, but that's obviously where people are bringing in unregulated drugs. But it's a good access point to support drug checking, all sorts of reasons, and make sure that they don't die alone. So again, big slide. This is just showing the variety of what we use. So we do prescribe various things for opiate use disorder. So that can be the typical oral therapies you've all heard of before: Suboxone, methadone, and Cadian is a 24-hour morphine. So just a once-a-day medication by mouth. We have the iOAT program. Again, more to come on that, but that's where people inject hydromorphone or Dilaudid, but a liquid form 3 times a day. And they can take a long-acting by mouth overnight so that they don't go into withdrawal overnight. And then they come back, and we're open 365 days a year. We have also subcutaneous injectable OAT, or that's essentially injectable buprenorphine, or what you would commonly think of as Suboxone, but just the active ingredient, not the naloxone component of that. We do a lot with stimulant use as well. So we do only oral prescribed medications for once daily use for people that are working with, that are struggling or wanting to work through stimulant use disorder. The injectable form, we don't really do that yet in Canada. It's possible that that will come. The heart attack risk is just so high that it's hard to have that be one that we can do safely at this point. But there's lots of and we're actually working. We don't have a slide about this, but we're going to be one of 5 sites in Canada that's taking part in a study for methamphetamine or crystal meth use disorder. And it'll be the largest study on the planet. So that will be kind of cool. So we'll be looking at high dose medications to take by mouth and seeing what the outcomes are. And the last chunk there, which Michelle will talk a lot more about in time, is our hepatitis C program, which is basically really rapid access for identification and treatment. So just this quick snapshot, as of July, the end of July this year, we have 320 people actively in the program. And so 274 are for opiate. Out of those, 70 are coming for our iOAT program, the injectable version. And there's a crossover, the people that are on stimulant use, so that's not exclusively. And on the very bottom point, 34 people are both oral opiate and also iOAT and stimulant. So it's a variety of people. So we have a lot of other supports. I won't go into tons because I could just keep talking, but we have a bunch of wraparound support. So we have the medicalized kind of stuff I just talked about, but that really is just to get people in the door in a way. And then all the other supports are the things that really, and that's part of what Steve's helping us with, is the things that make people's lives feel like they matter and that they feel cherished. So these are the other parts as well. So I think the last, and I'll be handing over shortly to Michelle, is so for iOAT in particular. So about, if you have 100 people with opiate use disorder, about 15 to 20 have already tried Suboxone, methadone, Cadian multiple times, and it's not really meeting their need. And they will continue to be exposed to the risk of death and morbidity, mortality from the toxic opiate supply. So Health Canada in 2019 said we can't leave everyone behind, so we need to come up with programming to help people. So a call was put out for, just to see who can try what. So we applied. We were one of 5 clinics or 5 programs in Canada that were given multi-year funding, which we're really excited about. And that was for us to start an iOAT and see what we could do to help. So I've kind of already gone over all that. iOATs are really well researched since the early 90s in Europe. It sounds new, but it's not new on the planet, but it's newer here. And the average time in iOAT is 3 years, not because we kick people out, but because they finally, after 3 years, can have a lot more of the other stuff in their lives stabilized. So they may not necessarily need to stay on iOAT, but there's no end if people want to stay on iOAT forever. And I'll hand it over to Michelle.
All right. So I'm also the coordinator for our nurse-led hepatitis C treatment program. We partnered with RECAP when we first opened because they had a very robust nurse-led hep C program. So we were able to partner with them, figure out what worked for us. And so our nurse-led hep C program in May 2016, WHO discussed a strategy to eliminate viral hepatitis by 2030. And Canada signed on for the strategy for the target for elimination. So elimination, everyone just assumes that's 100%, no more hep C anymore, but elimination by 2030, that looks like a 90% reduction in chronic hep B and hep C cases, 65% reduction in deaths, 90% of the infections are actually diagnosed, and 80% of hepatitis B are receiving treatment, and 80% of hep C patients are cured. And then also looking at increasing the ratio, having 300 needles, syringes distributed per person who injects drugs. So in Canada, the highest incidence and prevalence of hep C, it's found in people who inject drugs. 2/3 have evidence of current or past HCV infection, and 85% of new infections do occur among people that inject drugs. Traditional hep C treatment pathways fail to meet the needs of high-risk individuals, and they're also lost to follow-up, which I will talk more about. And this is taken from the blueprint. So there was 5 priority populations identified who are most at risk of getting hepatitis C. So people who are incarcerated, people who use drugs, Indigenous people, MSM group, newcomers and immigrants, and people, the baby boomers who were born between 1945 and 1975. It is recommended that screening is done for them at least once. So hepatitis C is a very expensive cost in Canada, and the further damage that is done with your liver, the more expensive it is. So by having hepatitis C treatment or even having screening programs to identify things early on, it would prevent the progression to cirrhosis, liver failure, and liver transplant. So at Riverstone, we realized that with the population we're dealing with, it's really hard to get them to attend multiple appointments because they're just trying to get by day to day, trying to get their next meal, trying to find a place for them to sleep. So sometimes their own healthcare is definitely on the back burner. And if they've been burned too many times, facing stigma, trying to access healthcare, then they're not going to. So luckily at Riverstone, we've been able to create a very open and build rapport with our population. So we have been actually able to eliminate, it says 5 visits, but we determined that it takes up to 9 visits for somebody to finally get on hepatitis C treatment, and that would be for general population. So for example, visit 1 would just be your screening. You go in and you get STI testing at a clinic. So you go in, you see a nurse or you see a doctor. They either do the blood work right then and there, or you have to go to the hospital or go somewhere to get the blood work. So that could potentially be 1 to 2 visits. And then those lab tests could take a few days to get back. So then visit 3, you go back in, receive your diagnosis. And sometimes at that point, the nurse practitioner or physician that's seeing you may not feel completely comfortable dealing with a hepatitis C diagnosis. So they'll either send you for further blood work, or they'll refer you on to an infectious disease specialist or a GI specialist. So that's just a whole nother slew of appointments, having to go and see specialists. And you receive your diagnosis, you go and you try to get more blood work done. Anyways, you can see this cascade, it's just never ending. So at Riverstone, we've actually been able to eliminate the 5 to 9 visits down into 2 visits. So we're pretty happy about that. Perfect. So we have been eliminating a lot of barriers when it comes to Hep C treatment, because right now in New Brunswick, only infectious disease, hepatology, and GI specialists were able to prescribe Hep C medications and receive the coverage through the New Brunswick prescription drug plan. So really, with the elimination on 2030, the goal is to have same-day starts or as close to same-day starts as possible. So we were actually able to get one of the infectious disease specialists to write a letter to NBPDP and just say, hey, look, we are seeing really high rates of Hep C. We're not able to get them to all of these different appointments. We would really like to have an in-house prescriber that can just help and deal with that. So in November 2022, we were able to get Dr. Davidson, prescribing authority. And in the meantime, we've been able to join Action Hepatitis Canada. We became a steering committee member. I became a steering committee member, and we were able to meet with government and just say, look, there are barriers to getting Hep C care. Only certain people can prescribe. I feel comfortable prescribing, and I'm not even licensed to yet. And then also there was just barriers with blood work and needing genotypes and fibrosis. Anyways, I won't get into that, but those are just a lot of barriers that prevent people from getting on treatment. So we've been able to eliminate some of those, and we're still working with the government to eliminate some more and be able to get more people to sign on and sign off on the special authorization forms for treatment. So this little chart here just shows how much we've been able to decrease active hepatitis C within our iOAT participants. So the blue column probably won't make a whole lot of sense to some of you, but that's okay. The one that I want you to focus on is the black column. So since Dr. Davidson has been able to sign off on these prescriptions, we've been able to decrease our active hepatitis C cases from 70% down to 40%. And I would say it's significantly lower now. I just need to update my stats. But just showing that we're able to drop it by that much by just coming and doing the 2 visits and getting people on treatment. So we are really proud of what we've been doing, and we were actually able to submit an abstract, and we're going to Switzerland next month to talk about our amazing program. So we're very happy about that.
Actually, just before I go on to this next slide, as part of getting the poster ready for that, we have in our zone 3, which is about the third of the province, that's the zone that we're in from our sort of healthcare zone. We, I believe during that same sort of 6-month period, we treated a quarter of the active hepatitis C cases in a third of the province. And that was just because eliminated barriers, had people that, you know, were already coming here all the time, but we're so far outside of the healthcare system. So yeah, super proud, and very proud that Michelle has taken, being part of that steering committee means that she's guiding our country now in nurse-led Hep C. So it's really a big deal. So we're pretty excited about Michelle doing an awesome job there.
And it's pretty exciting too, because a lot of the people that have had hepatitis C have had it for 10, 20 years, and they've just never felt comfortable accessing healthcare services. And now finally they have a great relationship with us, and they feel comfortable in being able to go through the treatment. So it's really, really great. So the next piece that we're going to talk about is just our values and how we like to run the show here at Riverstone. So Riverstone's care is patient-centered, trauma-informed, harm reduction, non-stigmatizing, and evidence-based. I won't go through it too much because I'm sure you are all of the same mindset. So participant-centered. I probably explain this slide a little bit differently than you do, but for recovery, I find that there's a massive expectation, maybe from government officials or other organizations that believe abstinence-based is the way to go. So they just assume the expectation is you stop drugs and everything is done. It's just one single line. But really, recovery, the reality is it's a bunch of spaghetti noodles all tied up together. So that's how I like to explain it.
I thought it was spaghetti noodle slide too, so I think we're good.
And just trauma informed. So where are people's trauma coming from, and what are their reactions when they're experiencing trauma? So just being able to sit back, listen to the participant, and being able to be with them. And you don't necessarily have to understand the exact trauma that they went through, but just having a nice motivational interviewing standpoint, really, and trauma-informed approach when you're dealing with somebody that has been through so much in their life. And then harm reduction. So if we can't eliminate the harm, we definitely reduce it. So that would be like safe supply programs that you were all from. And non-stigmatizing. So these are just some quotes from participants that we thought were pretty cute. So it's so nice to have people around you who aren't judging you for using drugs and who would notice if you don't show up. So we have an outreach program that if someone doesn't present for their iOAT dose that day, we are concerned about them and we are sending people out to go find them. And they make you feel like you're important. You're not just a patient, but somebody that they care about. It's good that there are boundaries, but it's a big deal to have them see you on the street and acknowledge you. And we're evidence-based. So we use evidence-based research and guidelines, but we also like to incorporate patient values. So we were able to create Riverstone by getting all of the feedback from participants, even opening hours, what kind of substances they would like to see, what kind of wraparound supports. We were able to have consulting agencies do surveys with participants at shelters and figure out what they would like to have in a recovery center. So evidence-based medicine is very important, but you need to meet the participant where they're at. So it's really important to incorporate their values. And then for our Health Canada funding, we're required to do reporting. So our project and research coordinator does iOAT surveys about every 6 months. And she was able to determine that 90% of our iOAT participants have positive changes in their lives since joining our program. And you can see here that there's been improvements to physical, mental health, less conflict in their life, and fewer interactions with police. Might need you to take over.
Oh, sure. Yeah. So this one wasn't actually being studied specifically, but Christine, that the coordinator, or the sort of research coordinator Michelle was talking about, just found a correlation that sort of showed up in the doing of the surveys, because we do ask about housing status whenever people start, and we check in along the way how they're doing. And so the people in the iOAT, so out of the, the 70 to 80 people that we have at any given time now in our program, about 85 have experienced homelessness at some point, and very often right before coming to the program. And then you can just see by those 5 steps, the longer that they were in the iOAT, the more likely they're to become housed. So again, roughly a third of people at the start were housed, but at the very end, after being in for 30 months, 92% are housed. And honestly, just like everywhere you folks are, it's not because we have a lot of great new housing for people who use drugs. So, I mean, we're working really hard on trying to advocate for that, but we're not successful. Our housing, we're in a massive crisis. So, but we just found this out. I mean, it was amazing to find this out, that this is happening. And as best we can kind of contribute, it's because people don't have to worry so much about the worst thing in their lives, spending all of their time in the day sort of staying out of withdrawal and getting whatever drugs that they're needing in order to just make it through the day, that they instead could focus on the other aspects of their life once they were on the iOAT program. And that's one of the outcomes, is people can just self-resolve in many ways some of their worst issues, like experiencing ongoing homelessness. So iOAT's impact on criminalization. So randomized control trials show that there's no increase in crime from iOAT programs. In fact, it's superior to methadone in reducing criminal activity. So for our participants, we were able to survey who have report having stolen to support their drug use. And you can just see here the various numbers of people that are no longer stealing or stealing much less. And the bottom portion is iOAT surveys who report selling drugs to support drug use before the program. And then people who are no longer selling or selling much less. And we're not really judging people having to do whatever they need to do in order to survive. It just, again, is another nice demonstration that if people aren't having their mental health issues or their sort of life experience criminalized, that it does free up a lot of energy. And the slide before that showed improvements in mental health, a lot of the things that they tell Christine, the people that are taking part, is not necessarily having to engage in that sort of day-to-day survival mode all the time, including having to engage in criminal activity in order to survive, has relieved their mental health distress a huge amount. So again, just one of the other benefits of decriminalizing people.
And just some participant feedback about iOAT, people feeling like it has completely saved their life. It's the thing that helps them. It has saved relationships, it saved their job. We've been able to take stress away from people. And one of Dr. Davidson's favorite quotes is while I was with the iOAT program, they made me feel like a human being and genuinely got to know us on a level of being human instead of as a homeless junkie. Even though we're homeless junkies, they treat us like we're not homeless junkies.
And another thing to add here that Christine says is the iOAT literally saved my life. She said it just shows up once on this page, but if it were for the number of times she hears it, it would like the whole screen would be darkened because it just is one thing that almost everybody, every time they're interviewed, has said. So we're really grateful that we've been able to have a way of touching people's lives in a positive way. Again, you sites that receive the tiny New Brunswick there is also highlighted, so that's where we are. But essentially, this is to look at, so the bottom half of that first page is just to look at the impact on participants' lives. So those are quotes from people nationally that have been surveyed as well. So very much the same thing. My life's getting better, life's so much better. I can devote time to hunting and keeping a job. So I mean, back to quality of life improvements from being on the program. And again, this is just page 2. So it's just to look at, just to really show the evidence that's being collected. So as much as we try to be a really cool space, we're also trying to contribute to the scientific evidence that is out there that other communities and other programs will be able to grow services through. So this is just showing in that top beige part, that's also just the benefits that people have also reported. So a lot of it having to be able to engage in much more life-sustaining, life-fulfilling activity. And then on this page, again, more information. Well, again, we'll have these slides available just so that you can see, but these are the positive outcomes that people are experiencing and the different resources and supports that our different programs are providing for people. And then just additional challenges, because we also have to learn from what's not working as well, or different gaps in areas that we're having to sort through. And we're certainly seeing lots of areas. We're trying to speak with our local government and nationally about ways that we could try to improve people's lives even more. And then a last bit here is just to how to look at supporting the staff, because to be honest, it's a pretty stressful world, and being part of people's lives when they're having the worst stretch of their life potentially ever is both an honor and can be really challenging at times to have to sift through and just seeing the barriers that people face. I mean, we're in very privileged positions where we're not having to live those barriers ourselves as staff members, but it just is, it's incredibly challenging sometimes, the moral distress that people who are bearing witness, whether it's family members, whether it's loved ones, whether it's staff, just really shows how collectively we need to find a way better response to treat people with compassion and in an evidence-based way. Last giant one, but this is basically just basically the safer supply information that we need to share, whether it's a medicalized version or whether it's a less more of a community-based version. So again, nice recommendations starting to come out initially. So I'll talk a little bit just about the national landscape, because we're experiencing a much more populist focus in the government. A lot of the stuff that happened in the States, I think, has unfortunately led the way to let you know, there's a whole bunch of reasons why it could be, and we need to look as a bigger picture as communities as to how we can integrate our relationships more appropriately. But it has led to, and there's often pendulum swinging, but we're definitely more of a right-wing populist backlash. And in Canada, the potential that we will have a government which is swinging much more to the right is very likely, unfortunately. I say unfortunately because they don't believe in harm reduction. So this is what I just wanted to offer this in particular as a demonstration of some of the things that are starting to happen, not to frighten anybody, but to help mobilize why generating the evidence is very important and why mobilizing together as communities to de-silo and share together is very essential. So this is just a screenshot from, and is iOAT at risk was me putting that on there. That wasn't on there. This is just the otherwise. The National Post is much more of a right-wing paper. You probably know that. And Pierre Poilievre, in particular, has been featured an awful lot in his point of view. And Adam Zivo is a reporter that really doesn't like safer supply. So there's a whole big focus on it. And for some reason, it's really taken the Conservative government and Pierre Poilievre by storm. So he would like to dismantle SUAP. And his leadership is unfortunately being sort of picking up steam here and there in different areas of the country. So we have to be really vigilant and try to do our best to maintain our communities and strengthen our ability and our voices together. This is just an example. In Alberta, the premier in Alberta, Danielle Smith, is very anti-safer support or safer supply. And what they've done already is they've amended so that pharmacies can still dispense methadone, Suboxone, and Cadian, but any hydromorphone tabs, which in Alberta might be used for people to take home and crush and inject as part of a safer supply option, they're eliminating the ability for pharmacies to actually dispense that. So whether it's been prescribed or not, they don't want to come across as seeming that they're controlling safer supply, but they're doing it in ways that are having that impact nonetheless, unfortunately. So it's just to show you that that is from the higher ups. That's the leaders saying people don't want this. This is how we have to change. It's unfortunately they're saying that it's actually helping the community. But as we can see from the next slide, that once they put all this in place, this past April was the worst month on record for overdose deaths. So by eliminating harm reduction and eliminating access to safer options for people who use drugs, it's actually putting people at incredible risk. There are iOATs in Alberta, but they've been taken over all by the province. And I know some of my colleagues there who are exceptional physicians in harm reduction have all been let go. So this is unfortunately what's happening. But the interesting thing is there was a poll that was taken, a sort of an academic study after these changes had started by Public Health in Alberta and in Saskatchewan to look at what people's actual opinions were on harm reduction. And so that chart that's on the right-hand side with all the long bar graph kind of things, the darker bar is showing people and their approval of safer supply options. And it goes from left leaning all the way over to far right leaning. And even if you look at the far right, the majority of people, it's a slim majority, but the majority of people that identify as right wing support safer supply. So it's really quite interesting that the leader is saying that people don't and that this is in the best interest, but the actual population, the people that see on the ground day to day, that know people, love people, are all saying the majority of people in Alberta, regardless of political stripe, are still in support of safer supply. So this begs the question, why is it, why is relapsing a crime? So in New Brunswick, again, just bringing the highlight back here, Nova Scotia is a little more progressive than we are here. And essentially, we have our public safety minister, who's not in charge of health, but who's in charge of jails and public safety. But I mean, that's honestly, it's more the incarceration, the carceral realm, rather than the healthcare realm or the social service realm, is looking at subjecting people to involuntary treatment. And you may or may not have heard that on the radio, but it kind of hit the fan over the last couple of weeks, just coming out saying that we're going to do this. It wasn't in consultation with any healthcare providers or with any Department of Health or New Brunswick Medical Society or with anybody. It's more of an ideological perspective that we have to clean up our cities and this is how we're going to do it. But as probably in all of your provinces, healthcare is so incredibly stressed. I'm not sure where they're going to find the healthcare providers that will be able to submit people to involuntary treatment when people can't even get into voluntary treatment. So I'm not sure if they're going to build they're going to build a big jail in his riding at the moment, which isn't justified as far as I can tell, but they're also going to be supposedly building, residential or sort of like rehab centers, which on one hand is really great, except if they're spending millions of dollars doing that, but they're not investing in housing, then I think that unfortunately it's just going to release people back to the street. And then the risk of overdose, once they've been forced to be abstinent and then they are released back to their known community living outside, is just going to result in people dying. So, and this has all been said and articulated very well to the government. We're hoping that they'll start to listen. So there's just a couple more slides. Decriminalization is certainly a big topic I think needs to be discussed further. This is again the CCSA. They're an excellent think tank and provision of evidence-based for sharing the knowledge. And so this is the summary of a large document they have. You can easily Google the name and find it online. But basically the top line says it all. A growing body of evidence suggests decriminalization is an effective way to mitigate the harms of substance use. So it's just coming out to say this is really where we should be heading. I would actually endorse that we should be looking at legalization and regulation of all substances. But decriminalization is at least a start. And as we've probably heard out in British Columbia, they're looking at decriminalization. They've undertaken that, and so studies ideally will show where that takes us. And so the key findings through that paper that we're just highlighting here is just looking at is obviously complex. And I already said everything's getting kind of left at the door of health to sort through, but really this is about housing, social inclusion, social capital, equity, poverty, food security, all the other things which really are not healthcare. So this has to be a de-siloing, looking at how everyone can work together, and really demand that governments take care of issues where they are, and don't just build end of the line emergency room oriented jails, sort of residential treatment centers. We need to push upstream much more, so really invest in people. And then decriminalizing is a whole range of things. So it's not going to be the same if we're looking at land-based needs than in a small reserve, in the Northwest Territories versus downtown Montreal. It has to look different. It has to be involving people that live there in self-defining and in helping to be participants and rolling out of services with people hand in hand. And then the growing aspect of evidence is just looking at that there's lessons that we need to learn, and that there are places we can start, that the gaps in knowledge, I think, are starting to close. There's a lot more work that's being done, but we do need to keep doing it, and we have to do it in concert with everybody who's at the table. Bring everyone to the table if they're not there already. And lastly, this is just looking at the spectrum of what decriminalization could mean. So the very far left, very severe criminalization. I mean, in some countries, death penalties do happen. We fortunately don't have that here, but we have the next one up, incarceration. And then just fine with the criminal record. If we zoom all the way over to the green side, commercial production. So that would be the legalization and regulated realm, which I think would be the ultimate way for us to get to, much like craft beer and I'll craft everything. Go to your craft meth store and pick out what color you'd like that day. Anyway, I don't get that public with it. I guess I am now that I'm online, because I do try to work within a decriminalization rather than a legalization. But I do actually think that that's the only way we're going to get ahead of the toxic drug supply, is to regulate and make available so that people can select what potency that they would like to try, rather than someone there, as a kid, their first try of an opiate is laced with fentanyl. I mean, it's just, the risks are just so incredible. We're beyond where we can turn healthcare into the way to control all of this. It has to be done through the public voice and demanding it all together. I don't know if there's anything at the bottom here that's the best thing to add. I guess, in fact, recent data indicates the countries, countries with the highest rates of drug-related death tend to have the most punitive approaches. So those that are to the far left are the ones that tend to deal, far left in this picture, far right in other ways, tend to have the greatest deaths. So it really just shows the more we can work with people and work where people are at and provide services people need, in a way in concert with everybody at the table, is the only way that we're going to get ahead of the toxic drug crisis that we're in. Did I miss anything?
I don't think so.
Like I said, I can keep talking.
Yeah.
And hey, it's 1:27. We left half an hour. Thanks everybody for listening. Happy to hear whatever your thoughts or questions are.
Thank you so much for that. I think Jill is going to come on and lead the Q&A.
Hi. Oh, thank you. Everyone can hear me, right? Okay. Thank you so much, Sarah and Michelle. That was an amazing presentation. I heard you guys speak. Well, I heard Dr. Davidson speak a couple of years ago to just our SUNAR network about the iOAT program, and I've been singing your praises ever since, because I just think Newfoundland could really use some programs that reflect what you're doing. And yeah, so I've been telling everyone I know. And it's great to see more evidence and the reflection from the people using the program themselves, and see how it's impacting their lives. And yeah, so there's one question in the chat. I will encourage anyone else, now is the time to put a question in the chat if you have questions. But Jill Allison says, I know that some people are trying to move away from the term overdose in favor of substance poisoning as a way of drawing attention to the inability to fully control what is being taken. So not really a question, but maybe you want to elaborate on kind of the innuendos of language related to that.
Yeah, I mean, I probably said overdose here and there, but I am also trying to say toxic drug poisoning. The one thing I've heard, interestingly, so I'd love to hear other reflections, is there's some curiosity around, does that imply that people who are providing drugs to each other are poisoning them? So there was some concern about saying toxic drug poisoning, because if people are sharing or if people are dealing on a low level, they really don't want to give the impression that people are poisoning each other. However, yeah, it is an interesting one to say, because it isn't really an overdose crisis. It's an unregulated toxic drug supply.
Yeah.
So yeah, I maybe said, or if I said overdose too much, I usually am trying to interchange toxic drug poisoning instead. But I welcome other reflections on what people feel would be more appropriate language if anyone has thoughts.
Yeah, thank you. I'll see if anyone pops up here. Someone, it looks like Steve asking me a question.
Oh no,
correct me.
I was posting it from the chat, so you didn't miss it. It's a little bit above me. It's from Diana Douglas.
Okay, sorry. They're all in the. Jill Allison said it is a complex topic, and I appreciate your answer. And then Danielle Lee says, I'm based in Vancouver, where some sites have been able to begin providing carries or take-home doses of iOAT. Do you think that's something that could be done in other settings?
We have, right now, we do 16 days worth of, we call them dispense doses. We're even trying to get rid of using carries, because if I'm providing someone with blood pressure medication, I don't say they get 30 carries a month. So just to destigmatize, but then we had a pharmacy say all meds are dispensed. So anyway, we're just trying to sort that out, but we're saying dispense doses instead of carries. But anyway, irregardless, we do have 16 days of that someone in our iOAT program, they do have to request it ahead of time just so we can arrange with the pharmacy. So, and that's just so they can have a break, they can do whatever. And if someone has a medical appointment, you know, court, child hangout, like some specific thing, we don't count those towards their vacation days. So we're trying to do that ourselves. I can think of a couple people in our program that are doing incredibly, you know, the rest of their lives have sorted out quite nicely, and I would love to have them have full dispense doses, but I'm hesitant to try to do that at this point, mostly because the doses that we're able to achieve here with having liquid hydromorphone be covered by our formulary, the doses tend to get relatively high. So to prescribe tablets to take home, it is just a giant amount, and to crush and inject the tablets at home, it tends to have people, I mean, again, we do that for the dispense days, but it's not a perfect thing. If we could actually have pre-drawn vials that they could take with their dose or some other variation, we haven't sorted that out yet. I know that in BC, they make a drinkable form of the blue juice, they call it. So there's things we're hoping we can look at, but I do think that in time I know that in the tablet take home programs that they have in other provinces that don't have the hydromorphone covered, the doses just aren't really able to get quite as high as they need to be to get ahead of the fentanyl crisis. So we're trying to do that here. But again, the injectable liquid form is just so much more potent. So yeah, it's not perfect. And I guess because we're relatively new, I don't want to risk not being able to exist by doing fully dispensed doses for people at this point. And I have a feeling the backlash would be significant until we have that as more of the norm in Canada. So it's complex too.
It is, yeah. And we have to work within the structures we have for fear of losing what we do have and what's working.
Mm-hmm.
So I appreciate that.
I think I saw a question on there about the ages in iOAT.
What's the youngest individual you've had on OAT?
On OAT
Yeah,
or iOAT?
It just says
on OAT. I had one person who came to my practice having just tapered themselves off, who was 14. The vast majority of people that I've seen, though, typically are in the adult realm, but 18. I mean, they can be 18-year-olds. But we're certainly open to providing OAT within certain circumstances. I mean, medically, best practices for people that are under 18 is to try to do other super, behavioral supports, etc. But we do have, unfortunately, a small cohort of people that are youth that are living outside right now, and I know that a number of them are at risk, and they just haven't engaged with our program at this point. But I'm not opposed to providing OAT for people that are youth. I would just want to be doing it in a collaborative way.
Sophie says, I'm always curious to find out more about the gender dimensions of services. Do you see any differences when it comes to needs or impacts of the program on people who identify as male, female, or gender diverse? Any insights or strategies would be appreciated. Thank you for your wonderful work.
Any reflections? I'm doing all the talking.
That's okay. You can continue doing all
Okay.
the talking.
It's interesting. We haven't fully teased out necessarily a secondary analysis of our surveys based on outcomes for people who identify as male or female or other sort of gender identities in particular. I guess I'm thinking out loud obviously here, but the psychosocial realm, people who are living outside, obviously if they're, well, maybe not obviously, my noticing is that if they're identified as female or trans, they definitely are at much higher risk. And so there's a lot of different nuances around surviving living outside, needing safety, needing to engage in survival sex work, needing to provide services in order to be able to stay in a tent. There's a whole bunch of nuances there. So I think it's identifying, and the fact, people being able to identify sexual violence and experiencing sexual violence is incredibly impaired is the word that comes to mind, but it's just unfortunately so common that it's not captured in that's one thing we've noticed is people don't even really identify what they're experiencing on an ongoing basis is sexual violence. So there's a lot of safety elements, I guess, to consider for people but that's not so much about the iOAT piece. That's really, now one thing I guess I could say too is people who are in heteronormative relationships, often the male might be the one who's injecting themselves first, and then the washes are given to the female partner, or the male is doing the injecting and the female partner might not be doing the injecting. So there's a little more support and training because people have to self-inject in our program. So we do need to provide a little more support for people who maybe were the recipients of being injected rather than doing the injecting, and definitely be aware of screening for Hep C because someone who's got someone else's washes is going to be at higher risk of sharing whatever they've got. Any other gender things?
Yeah, I've definitely had a couple of people, a couple of couples where one of them only had hepatitis C and the other one did not at all. So I thought that was actually quite interesting. And just coming from, I'm also a sexual assault nurse examiner, and just predominantly you see a lot more females who are homeless that have been sexually assaulted, but that may also not be correct because I think that a lot of the males just start coming forward and accessing the care.
And in our surveys that Christine's doing, and she's people know who she is. They call her the donut lady though, because she comes with donuts to do these surveys. But she's also around the clinic here and there. So she's a little tiny bit removed, a trusted face, but a tiny bit removed. So it's kind of nice because they'll tell her things that they don't want to disappoint the doctor or get in trouble with the Queen of Swords here. So they may not, but she's actually found that every single person in our iOAT program is a victim of sexual assault, regardless of their gender identities. So, it's super common and tragically. But yeah, I guess there's a certain, just all the typical stuff that people's different genders might avail themselves with, or might cause issues in the psychosocial realm do play out, and often with more of a dramatic version here.
I have a question before I ask the next question, because I'm someone who's a person who used to inject drugs, and I just think if I had access to a program like iOAT at a time where OAT wasn't enough, that was how that was my path to stability, was through methadone. But what role would child protection services play in a woman's, like if there was, do you see that? Do you see the social workers getting involved because the mother is part of your program?
Yeah, I find, unfortunately, the majority of the people that are in our program don't actively have their children in custody. I think just thinking back to the continuum, I think it's to the point where it wasn't so much like a habit that they were forming. It was at the substance use disorder stage. So usually at the point that we're seeing our participants, they don't have custody of their children anymore, but our case managers, our social worker in particular, works with child protective services. And a few of our participants will work with them to make sure they get supervised visits, or we just try to work with them to figure out a goal or a long-term plan and how they can get their children back.
Mm.
But I guess even we've had a couple of pregnancies that have gone through our iOAT program, and people still have custody of their child because they had the right supports in place. So I think that's also a really big deal too.
But they had to go over to oral therapy. It wasn't something while they were on the iOAT
Yeah.
program that was going to be seen as possible. But I guess the other nice flip side is that we've had a lot more people say that they have access to family again in a way that they didn't before. So as much as they may not be in their custody, their children might not be in their custody, they have more relationship with their children or their grown children, especially in some cases, because we have a really diverse age range.
Mm.
So there is a benefit to that, but it still is to the point where I don't imagine that anyone would, well, I don't know. I guess it's hard to imagine child protection being in support of someone who's in the iOAT program and having their kids. So we're just trying to find our best way to support people as best we can with where they're at.
Yeah, and hopefully in the long term, part of the research findings will show that, after years and all those supports in place, young moms, I'm thinking young families could be restored with their children, have that
Yeah.
custody back. That is the dream. Okay, next question. Do you think more healthcare providers would be willing to support people who use drugs if they were decriminalized or legalized? What role, if any, does the overprescribing crisis from a decade ago play in healthcare's providers' willingness to participate in iOAT or safe supply programs?
You can take that one.
Okay. Again, I just keep talking, so I'm trying to share. Yeah, no, I definitely, I mean, when I was in medical school, I went into medical school when I was quite a bit older. So it was certainly hammered really hard into our head, like do not overprescribe opiates, at 200 milliequivalents of methadone, or sorry, of morphine per day is danger zone. And you know what I mean? So it was, and I mean, in a way that's good, I guess, because there was a phase, and everyone who's been watching some of the shows that are coming out about the Purdue Pharma and stuff like that, I've seen that, yeah, and that was in many ways a very typical, like a targeting of vulnerable populations to make a hell of a lot of money, which is different than prescribing opiates for pain. So, you know what I mean? It's really, really complicated, but there's definitely a lot of reticence, a lot of hesitancy to prescribe opiates. And I think that's not a bad thing. I'm also a family doctor as well as medical director here. And I can count on one hand how many people I've started on opiates for pain versus people that I have had come to me already on, massive amounts of opiates, and trying to work with them in the way that I can. But that's again from opiates aren't great for chronic pain, to be honest, despite, I mean, people that have chronic pain find relief from it. So again, that's a whole other can of worms I don't need to open here, but there are other ways that we can work with pain. So on one hand, but again, this is a whole other realm. This is about keeping people safe. This is also about, in that substance use continuum, people might be using substances out of recreational wanting to use substances, and they still shouldn't be at risk of dying from it. So there's a lot of stuff before it becomes a disorder. But anyway, all that being said, it's complicated. The kind of crisis that people see, a lot of doctors that I've experienced, the questions they have, they're worried about enabling people. They're worried about, that they're making something worse, because that's typically doctors don't want to be making anything worse. So I believe that there would be a ton of hesitancy. I'm involved in a couple different organizations trying to look at ways to create much more education and standards on a bigger scale. My hope would be that we'd be able to have more physicians be involved in prescribing safer supply options or running iOATs or all sorts of a variety of ways. But I don't actually think that we're going to get there ahead of the toxic drug supply, which is why I'm endorsing regulation and availability of non-lethal substances for people. Because I also think on one hand, to have doctors be involved, like there's, I don't know, a few dozen people in our program that I don't actually think need to come here to see a doctor. I think they just need to have access to a supply of medication that won't kill them. And I also think that by having the healthcare system try to absorb and be the answer to this whole issue is really just not practical. We can barely get enough hips and knees taken care of. As they talk about the capacity for healthcare to be the response is just, there's so many more things that people need out of healthcare. So I would like to think that there could be more physicians and nurse practitioners, nurses all through the spectrum that are trained, engaged, wanting to help, but I don't think we're going to get to a full, robust solution through healthcare alone. I think if people fall into the realm of the disorder, like I've got people again in my family practice who drink alcohol. I've got a lot that drink alcohol, but I also only have a couple that have a severe alcohol use disorder. So those are the ones I should see for a healthcare treatment. The others that are drinking alcohol should be able to drink alcohol. There are guidelines from a public health point of view. So there's a whole bunch of different lenses that we could look at trying to address the toxic drug poisoning. Through a public health lens would be an excellent one. Through a lot of education and support, and again, through regulation and decriminalization first, but regulation would be another great way. And I think ultimately it's removing the drivers behind a lot of, if people are in crisis and using out of a way to deal with trauma, it's again addressing all those other elements. So people that are housed, well supported, that have social capital engagement with a chosen family or perhaps their own bio family, that have meaningful engagement in whatever they'd like to be doing day to day, and then have just communities to feel safe within, may or may not need to use the same amount of crystal meth as people that are living outside in a tent trying to stay awake. You know what I mean? So there's a lot of ways that we can address this. And I don't know that getting enough doctors on board is the answer. I'd like to say we can get better and that we're doing all we can to educate our regional healthcare providers. We have a lot of nursing students, PSWs, medical students that come through Riverstone, which is fun because we're like a cool spot. But I think we need to do more of that, but I'm not sure that we're ever going to get in front of this. So I don't know if I fully answered the question, but those are just really important points I feel to say that we need to address this through multiple lenses, and it's not all a healthcare issue by all.
No, I agree too. And I will add that there are so many skilled people in that realm of people with lived experience that want to help and want to be part of the solution. And don't need a medical degree in a lot of aspects to be able to provide the supports. I think of Refix in Halifax, how it's a peer-led supervised consumption site where they've got the training, it's empowering them. There's way more creative ways we can help solve this crisis. Kathy I'm not going to try to pronounce poor Kathy's last name, Gaguin. She'll probably get mad at me later. If a person who has been on methadone for a long, long time, should this person stay on the methadone for life? Or is there something that may be better for health reasons in the long haul as we get older?
So after being on methadone for a significant amount of time, it does do certain things to your body. Unfortunately, but it's the same with most opioids anyway. It deteriorates your bones, and some people find that their teeth are falling out. Opioids lower your testosterone, and yeah, so those would be concerns if you were on methadone for a long time. But if someone is successful, they feel like they're doing great on methadone, there's not really any reason for them to switch. Some people might be on methadone lifelong. Here at Riverstone, we just meet the participant where they're at. So if they want to be on methadone for the rest of their life, cool, we'll support that. If they want to try another therapy, we'll support that too. So it's just whatever their definition of recovery is, or however they feel they can be managed with their substance use disorder, we will help them with that.
And I'll add in just a little bit too, that I agree everything with that Michelle said. And all medications have side effects.
Yeah.
So there's a whole class of medications called anticholinergics, and they make your mouth very dry. So any of the dry mouth medications, which can be blood pressure, heart disease, all sorts of stuff, can also be at risk for reducing your saliva, which makes dental caries get stronger and teeth fall out. But the methadone does reduce a bit of bone density, which then is sort of a double-edged sword for kind of bone care. Methadone itself has also a lot of drug interactions. So it's now second line in Canada, Suboxone being first line. Suboxone is a partial agonist, so it hops off and on the receptor, whereas methadone plugs itself right in. So for risks of overdose, if used with other substances, alcohol or benzodiazepines or what have you, is higher on methadone than Suboxone. And kids, if they get their hands on it, don't tend to overdose because they don't hold it under their tongue long enough. They just swallow it. So it's a much better safety profile with Suboxone. But all that being said, as Michelle said, by having meeting someone where they're at and what their life goals are. Some people have tried to come down on their methadone dose and not found that they can tolerate that very well, and the risks of them relapsing is much greater harm. Other people, though, when they have a really super slow taper, have been more successful coming down to a dose. But it's like, because, in those first few slides, a chronic, relapsing potentially or remitting, you can go into remission for the rest of your life on something like methadone, but it might be that it's kind of like if someone has diabetes, they might be able to get off insulin one day if they suddenly magically have great food security, they don't have chronic pain, so they can exercise like crazy, and they've got enough income and they don't have to work 3 jobs. Like, there's so many variables that could then maybe get someone off insulin potentially, but that might be 5%. So people that are on long-term opiate agonist therapy of whatever type, I think people that go for pure abstinence is a much smaller percentage than those who are stabilized on a dose. But again, it's super individual. Some people are just, they've got a plan and they want that plan to come, and we work with them wherever their plan takes them. And we really, one of the things we try really hard here is to make sure that the person feels like they're in the driver's seat, because they often have not felt that in every other area of their life. And if they can feel that here, then maybe they can start to model that elsewhere. So don't know if that's fully what
Yeah, I guess
Kathy was looking for, but
I think maybe, yeah, I mean, Kathy can comment if there was anything else, but because I can relate to the question, and I think you answered it, like maybe Suboxone is a healthier option for you in the long term. But again, that depends on the person's will, like, do they want to do that?
Yeah.
That's a process too, right?
Yeah.
Yeah.
But hopefully whoever is doing the prescribing can have that kind of open-ended conversation and figure out what the person, and often people will know really well what they need and how they're going to get to that point.
Yeah.
So
Exactly. Well, that is the end of our questions, unless something pops up. We are 10 minutes before the close of the webinar. I want to thank everyone for signing on and being part of the conversation. I imagine most people who signed up are going to catch the recording, which I'll remind everyone now you can find on sunar.ca, our website, within a week. There's a new question from Gary. I don't see it in the chat. Oh, there it is. Okay. Gary says, I've been on methadone since 2019, and it's my 3rd time on the program. I've noticed I've been sweating a lot more on methadone. Have you heard anyone saying the same out your way? Yeah.
Well, I'm going to be a little careful to not give medical advice without knowing much more. So I'd say for sure talk with your prescriber. However, in broad strokes, opiates of any type can cause sweating, and withdrawal can cause sweating. So it's always like, plus, people with ovaries, menopause can cause sweating, you know what I mean? Diabetes, like there's so many things that can cause sweating. I have heard that before though, Gary. I'm not trying to evade your question, but sometimes it's getting your dose right. Other times it's if you're more active and then you're using up your dose a bit more, you can suddenly have a little micro withdrawal and it can lead to sweating. But it's really important that you get all the other potential underlying health issues assessed, just so that you know, because I don't want to just say, oh yeah, it's just that, no problem. But definitely, I have heard that, and it's both from either any opiate or not enough opiate to get to a stable point can cause sweating. So it's a tiny bit of a pickle to sort through, but step by step with your prescriber, I hope you can do that.
Thank you. Gary says,
Maybe I'll give a tiny plug, riverstonerecoverycenter.ca, or no, is that actually, it's Recovery NB. Google Riverstone Recovery Center. We have a ton of info on there. We'd absolutely love for you to come check it out. We are also, we're on Facebook and Instagram, if you ever want to hop on and share with us there. There's, for those of you that are in New Brunswick, I'm medical director for the Atlantic Mentorship Network, and Michelle is one of our mentors. We're trying to work with chronic pain, addictions, and mental health to build up kind of networks and capacities. So you can always reach out if you're interested in learning more, but that'll be workshops and connecting in small group learning about addictions and mental health and chronic pain. And I'm going to be in Newfoundland actually in a couple of weeks, so I'd love to see whatever harm reduction oriented things are. I'm going to be in St. John's though, so if you're okay, if you're anywhere near there, let me know.
Yeah, I will.
Please reach
Yeah,
out.
this is
I'd
where
love to
I
come
am.
visit.
Yeah, yeah. Well, I could probably point you to the best places to visit.
That'd be awesome.
Okay, and I wanted to say before this ended, Michelle, I thought that was incredible, the whole presentation around Hep C. That was the first time I had heard about that project, and so as a in my previous life, I was a nurse, so I'm really just beaming with pride that this is a nurse-led initiative, and it's so way to go.
Thank
Way
you.
to go with that. Yeah, thank you. Steve probably has some words to say, and then we'll close.
I just wanted to say thanks, but I didn't have anything planned. But I'll see you on another webinar in like 4 minutes, Michelle. Thanks.
Yep, I'll be there.
I'm just really proud to work for both these organizations and for